So, in continuation of our talk, the part B of my talk is how do you pick a right surgeon? So, in the last session we spoke about picking a hospital. Now, picking a surgeon is equally important or even more important, and some of the points is to just guide you to make the right decisions. Now, what is happening today? So fundamentally, it is still a word of mouth reference. People ask around who's the best surgeon for a particular procedure. Then there is quite some branding done by institutions or entrepreneur surgeons regarding their skills and marketing. And the big problem which I notice even today in the Indian scenario is to find appropriate subspecialists. So there are quite some well-trained subspecialty doctors, but they're not finding the right patients, and even more important, the patients are not finding the right specialists. And why does this happen? The biggest reason why it happens is a lack of general practitioner who can guide the patient to the right surgeon for a particular problem. Now, the second thing, what has happened is the internet has become like the California gold rush, where people are making any sort of claim, and that has really muddied the waters. So what are the problems with this particular model? There is dissatisfaction with ultimate outcomes. The care delivered or the care taken by the patient might not be to a particular level of care which the patient deserves. It increases complications. The other side of the coin is surgeon disillusionment. You will have people who have trained 5-10 years extremely hard to get certain skills, and they are disillusioned because patients don't find the right surgeons and they feel this country does not respect expertise. Now, ultimately what it does is it makes the entire doctor-patient or the surgeon-patient relationship transactional, where it should be a translational relationship with great search for meaning. Now, how does it work in a Western setup? Now, this is an example I picked out of where I did my fellowship training in Mass General Hospital. So when you search for orthopedic surgeons in Mass General Hospital, there are 60 results which pop out. By the way, Maurice is my mentor in Mass General during my pediatric ortho fellowship. His name popped up first. So in one department in orthopedics, there are 60 orthopedic surgeons. What it essentially means is orthopedics is divided into various subspecialties. He practices pediatric orthopedics. You see Dr. Asnis practices sports medicine. So there is ton of subspecialty practice which happens. So what it means is there's a streamlined process of referral, streamlined process of care, where they gain their domain expertise by working in that particular specialty and they become experts in that. Now, why does it work? In the Western system, the system is structured around excellence. So patients want good results. The systems are designed for that excellent outcome. And that is by a streamlined referral pattern. So the general physician in that particular community knows who's the expert in that particular specialty, and he or she refers them to that particular doctor. From a surgeon's point of view, subspecialty training is intensive. It incentivizes. There is a lot of incentive to not just financial, but also the kind of love and passion you have for a particular specialty. You'll be able to practice that particular specialty. Now, in the West, the advantage is there's a clear-cut database of accreditation. So if somebody claims to be a board certified expert, you can verify their credentials easily. Or whatever I spoke is in the American system. When we look at the more European, UK-based models, where largely the government pays for your care, then the financial incentive goes, the pure joy of practice takes over, and still the referral happens to the right kind of doctors, the experts in that particular domain. So we have looked at the existing problems, we have looked at the large Western models. So in my experience over the last 25 years practicing medicine or surgery, so what I've learned is there are certain 4 basic traits which defines a surgeon. So what is their knowledge and training? What is the experience they have? And for me personally, the last thing, empathy. So these 4 metrics decide if a surgeon is a great surgeon or not so great surgeon. So let's look at each of these points. Knowledge and training I'll address together. Now, person's training is critical for foundational knowledge. What I mean by that is, the starting point of any postgraduate training is MBBS. So most of them start pretty much at the same baseline. That might be a private or a government college. Their entry point to a specialty is pretty much the same. But when we look at the training streams which are available in this country, basically master's program, so master of surgery or masters in orthopedics, gynecology, are generally better structured than a diploma or a DNB. So masters are for 3 years, diplomas are 2 years, and DNBs are generally 3 years. The structure of the educational program is a little more rigorous in a master's compared to a diploma and DNB program. Now please, whatever I am telling is on broad strokes. There are exceptions to every point I am going to make here. So please understand the core of what I am trying to deliver. Now similarly, when people go into medical colleges, government medical colleges are extremely competitive compared to a private medical institution. So the input they take are some of the smart people, and they put them in pressure cooker kind of situations. They come out as smarter, well-trained surgeons. The same problem affects the super specialty courses. There is a pyramidal system. When we look at the super specialty courses, generally in surgery, it might be a urologist, surgical oncologist. The same thing, government college has a lot of patients coming in with some infrastructure issues, whereas the private training program might not be as robust or as intensive as what a patient, as a surgeon gains in that particular government setup. So what hierarchy can we see? How do we respect the institutions? The general consensus is the central institute, something like a NIMANS, AIMS, PGI, SGPGI, Lucknow. These are some of the most competitive institutions. So people going into those institutions are generally pretty smart, and the training programs are rigorously designed. So when they come out as good to great surgeons. The next hierarchy I would suggest is the government medical colleges across the country. In the 28 states of our country, the various government medical colleges, majority of them have huge volumes, and day in and day out, they look at the variety of problems and they come out as well-trained surgeons. Now there are certain missionary hospitals and they have their training programs attached. So they do a fairly good job in bringing out good surgeons, and then comes the private medical colleges and DNB training programs in various institutes. The hierarchy is fluid but general accepted. People coming out of central institutions are well-rounded and grounded surgeons, whereas DNB training pass out might not have the same skills and experience what a pass out from a central institute surgeon has. Now talking of super specialty training, in India, unfortunately, the super specialty training is not very well defined. It's still evolving. It's a process. Now let's take general surgery. We have plastic surgery, urology, GI surgery, where already certified MCH programs are available. But what you have to remember is, in the West, plastic surgery has 6 to 8 subspecialties. Burns is a separate specialty, facial reconstruction is a separate fellowship, hand surgery is a separate fellowship after plastic surgery. So there's extremely well-defined systems where a person training in that particular fellowship or that particular stream becomes an expert in that particular specialty. Whereas in India, we're still not there. There are centers where there are surgeons who are practicing that and they have apprentices come to them and learn, but it is not as structured as what we see in the West. So like I said, the same problem afflicts my specialty orthopedics or gynecology or ENT. We still don't have robust subspecialty training programs. Now, when you look at UK training, a lot of surgeons have come back from UK. So they have 2 degrees which are given in the United Kingdom. One is MBBS and the equivalent is MBBCH. So, but basically both of them are same. Then you see MRCP and MRCS. So what you have to understand is MRCP or MRCS is just a membership of a Royal College of Surgeons. It's a basic entry level certification which is required to get into a surgical training. So essentially MRCS doesn't mean anything other than a certificate where the doctor is qualified to enter into a surgical training program. The FRCS is something post training. The fellowship is offered by the Royal College of Surgery. Generally, there are 4 universities from which they get it: Glasgow, Edinburgh, England, and Ireland, where the FRCS means that they have attained a consultant level skill in surgical training. And even more important is CCT training, is completion of clinical training, where they essentially becomes consultant in UK. So if somebody has done a CCT training, you know that the person has reached the consultant level in that particular stream of training. Systems which, quite some surgeons have started to come back from the US. So the American system is slightly different. When you see a lot of doctors put MD next to their name, in India MD means a postgraduate training, whereas in the US MD means generally Doctor of Medicine, which is equal to MBBS. There is a slightly alternative stream which is available in the US. It is called as DO, which is Doctor of Osteopathic Medicine, but MD and DO are essentially MBBS level training. So once that is done, people go into a residency program. Many surgical residencies are 4-5 years. Say orthopedics is a 5-year residency program, surgery is 5 years residency program, where they become board certified or board eligible. And once a surgeon is board certified by the American boards, they reach a particular consultant level skills. Now the next level in the US training hierarchy is a fellowship. So each university offers a fellowship. So basically the fellowship is designed in such a way that under a particular mentor who is an authority in that particular speciality, the mentee or the trainee goes there and learns that skill for either a year or 2 years, literally becoming experts in that particular subspecialty program. Now, talking of the fellowship training which is there in our system, you can see that the Indian fellowships largely are not well structured, and the other downside to that is many of them don't have hands-on training. So in my fellowship program in the US, both my fellowship programs, there was every 3 monthly 360-degree evaluation. I was evaluating the program was evaluating me, and at any point of the training program they could fire me if I was not meeting basic standards. And similarly, the program were accountable to give me certain amount of hands-on training, so that at the end of my fellowship I would come out as a well-rounded surgeon to be able to tackle the problems in that particular field. So many clinical fellowships in North America are for 1 year, surgical fellowships. Some surgical specialty fellowships are 2 years. In Australia and UK similarly, the fellowships could be of 6 months. There are certified fellowships for 6 months in these countries. And a lot of people travel there and do what are called as observerships. Essentially, they don't touch the patient, they don't operate. Basically, they participate in academic activities, see how the system works. But observerships are not clinical training programs. Now, the biggest thing which we see is slides like this. So you see that there's a lot of so-called fake things, and in fact, I was asked by one international patient saying that essentially many doctors in India are fake. Is it true? So even though it makes my blood boil, there is some truth to it, because a lot of care being delivered in rural to semi-urban areas is being done by not properly trained professionals, and these things take a lot of highlight in the internet and the media, and this literally sets up for a problem. Now, I just finished my fellowship, I came back to India, I started my practice. I had one of these international coordinators, international tourism, medical tourism coordinators come to my room, and I just explained to him that these are my domain expertise, these are my skills. And the next thing he told us, doctor, I can tell you names, so-called big names, where they have not done any training, but they just try to claim all sort of fellowships. At that point of time, I was literally angry on the guy, but he told it dispassionately, and that got me thinking. So this is my room in my practice setup. I put up all my certificates, not to boast, but it's just to say that, look, I'm credentials and I'm capable to do the kind of surgeries I claim to do. So whenever you see a doctor generally who's done their training, you can see that they would have put up their credentials, And this is one very easily verifiable way of their particular training programs. Now, what is the research you can do? So how to do research when you look about a surgeon is you can go on this nmc.org.in. So NMC is National Medical Council. Previously it was called as MCI. So now NMC is taken over, and this information desk has all the list of colleges and what training programs are there. If I claim to have trained from a particular institution, you know what year that particular training program was commenced, and you can look it up online. Now in the United States, the simple thing is what we call as a NPI number. So this is again my NPI number. So if I claim to have treated patients in the US, all you have to do is search for the NPI number. There are very few fellowships where you're not allowed to write a prescription, but if I've treated patients, I generally have to have an NPI number. You can Google the person's name and NPI number and you will know if they've done their training. Similarly, in the United Kingdom, GMC registry has speciality residents and general practitioners. Even you can look up on their registry to see if that person has done their training there. Now, how do you assess academic accomplishments? So most folks who do academic research, especially who have domain expertise, publish their work. They're expected to do some research and publish their work. And generally publications are a lot more valuable because they're a lot more rigorously evaluated than a conference presentation. Many a time you see the claims of doctors who say that I've done hundreds of publications and many conference presentations when you look at their profile online. But a simple way to look it up is you can go on Google Scholar or PubMed to really see how much publications they have, and it's very easy, you can do it online. Now, former head of Royal College of Surgeons, Lord Smith, made this statement. It would take me 1 year to teach a trainee how to do a surgery, 5 years to teach them when to do the surgery, and a lifetime to teach when not to do. So what it essentially means is there is no substitute for experience. Experience is critical in the maturity phase of a particular surgeon. Now, surgeons are like wine. So the more they age, the better they get with age. It is not just the motor skills, it's also the intellectual skills, the decision making process. It's a complex, surgery is just not about cutting open a patient and doing a procedure, but it's a complex amalgamation of appropriate timely intervention, doing the least necessary to make a patient better with the lowest amount of complication, and that takes time to learn. The only thing is, it's like the oldest surgeon might not be the best, which I'll tell you guys in a minute. Now, there was this model essentially described for pilots. It's called as a Dreyfus model of skill acquisition. So when we look at the way skills are acquired, most people begin as a novice, goes through an advanced beginner, competence, proficient, and an expert. So this takes time. So from a novice level to an expert level, people mature over 5-10 years of time, doing the surgery over and over, looking at their own complications, polishing themselves, and then they reach this proficient to expert level. Now, what is the ideal experience you are looking at? Age as a surrogate for experience is not very accurate. Why I say this is, some hospitals you can have surgeons doing just 10-15 surgeries a month, whereas some hospitals, some surgeons are operating 50-60 surgeries in a month. So their experience might be vastly different, even though they are of equal age, the cumulative experience will be very different. So this was the 10,000 hour rule was popularized by this guy Malcolm Gladwell. But essentially it can be applied to surgery. So once a surgeon keeps operating, when they do about 10,000 hours of hands-on work, they reach a level of proficiency, not just the dexterity of the hand, but also the clarity of the mind. So out of my own personal experience of how I have matured and talking to colleagues, and the consensus is post-surgical training, after 7 to 10 years, people reach a certain level of maturity and competence where they really reach their top of their game. Now, when I spoke of the volume, does a surgeon's volume matter? When we look at the data again, that's very clear. the doubling of surgeon volume was associated with a 4% reduction of adverse outcome. This is all vascular surgery, the first one. You can see you can see that there was almost a 10% reduction for aneurysm surgery and a 4% reduction for a carotid endarterectomy kind of surgery. Whereas when we look at surgeon volume and infection even in orthopedics, there was sufficient evidence to say that high volume surgeons tend to have better outcomes compared to a low volume surgeon. Now, what's the ideal age of the surgeon? Now, based on the 10,000 hour work rule, I think surgeons reach their competence of being a good surgeon by around 35 years of age. That is not the problem. Generally, people look out for experienced surgeons. The other problem is actually the problem of the aging surgeon. Why this is important is, once we start getting older, there is a physical decline. Our strength decreases. By the age of 65 years, we've lost about 25% of our strength. People, when they reach about 55 years of age, they start developing visual problems. And this is important because we are operating in bright light. A lot of surgery is extreme dexterity. And even more important is something called as remoteness from education. So science is changing at a very rapid pace. If a surgeon is 65, essentially he finished his surgical training about 40 years ago. So what techniques he learnt during his training are essentially obsolete at 65 years. So they have to adapt. I've seen some senior surgeons whom I work with, I have huge respect. Some of them are the smartest surgeons, but generally remoteness from education, the skill acquisition, all of this decreases with time. And other than exceptions, post 65 years, there is a significant decline in a surgeon's performance. So the upper limit, based on evidence, we can say the cutoff is probably 65 years. Again, this is a lot more controversial. So I'll give a small example. I was doing my fellowship with a world-renowned surgeon called Ken Krakow, with whom I learned joint replacement. So I was doing a revision surgery with Ken, and we did about 6-7 hours surgery. He was 67 at that time. He had himself undergone many surgeries. He had arthritis in his hand. He comes out tired. He sits down. We were having a coffee and he asked me, should I be doing revision surgeries? In my bones, in my gut, I knew the answer, but I literally worshipped the man. I did not have the courage to give my honest opinion. But generally speaking, post 65 years, there are issues which can come with both strength and endurance and decision making. Now, certain surgeries requires domain expertise. People become proficient with repetitive procedures. Some guys just do joint replacements or hysterectomies or cataract surgeries, bypass graft, spine fixations. So repetitive activity makes them subspecialty training offers that, or if they've just been doing that, they literally become experts in that. Now, we spoke of knowledge training and experience, but this is something which is very important for me personally, and I think it matters in patient's care: empathy. Now, for people, it's very hard to judge empathy, and basically empathy is a feeling of care. Now, how do we know a person if the person is empathetic? Active listening versus passive listening. Many a time you will know that the person is putting his heart and soul or her heart and soul when they are listening, vis-a-vis that they are just being physically there. Distractions. One of the big problems of modern lifestyle is a distraction. Just now you saw that I cut off a phone call. So this is a big headache. But how do we handle those distractions? How does that surgeon, he or her, handle it? And how is the non-verbal communication? Are they sharing their thoughts? Do they console you if there is a complication? So those non-verbal communications matter. Some surgeons I've seen are very sticklers for appointment, but I honestly think patient needs are much more important than being stickler for appointment. And the way you can pick up empathy is the words they use. Is it we or me? So any surgeon generally who speaks of we believes in team approach, and they are good communicators. They listen to their assistants, they listen to their scrub nurses in the operating room. Vis-a-vis the me kind of guy, what you have to remember is the me kind of person, generally the alphas are a bit of narcissism. people are scared to give them feedback, and essentially they reach a point where they stop growing as surgeons and they plateau out. Now again, how is the description of a procedure and its complication? If anybody guarantees you 100% success, please avoid them. There's absolutely no surgeon in the world who's not had complication. And one of the ways which I have found useful is request to talk to a patient who has had complication. Now this is a very fine line. Many surgeons might not be comfortable because patients generally might have a complex understanding of their problem and they might have a negative feeling. But a real patient would appreciate how effort and what was the kind of thought process which the surgeon gave when that patient had a complication. Again, I picked this up from Ken, and I have been surprised that many a times patients who have had complications with him have referred patients to him, because empathy was something which was written all over that man. So talking to complicated patients of a surgeon, complications in a patient who's operated by a surgeon would give you an idea of his empathy. And please remember, it's not the quantity of time, but the quality of time spent which matters. Now, female surgeon. There is a subconscious bias which still exists against female surgeons, except in obstetrics and gynecology. In other specialty, I've heard patients say, can I operated by this lady or should I go to a male surgeon? Now, please remember, this is a data where it was done in, I think in New Zealand, where they looked at more than 1 lakh patients, and not surprising to me, but for a lot of people, is that fewer patients operated by female surgeons had complications. Essentially, we know that women have a lot more maternal instinct. They are lot more caring. I am more than happy to agree to it. So that translates even into their surgeon behavior, and that data is clear. Not just in surgery, even in intensive care, they've matched the ICU specialists or physicians, and they've seen that female physicians and female surgeons generally have better outcome than male surgeons and male physicians. It is not to say that a well-trained male surgeon cannot do a good job. It is just that the gender bias should go, and anybody who's competently trained can do a good job. Now, the cesspool, which is the internet. The big problem I see is there's too much of unverified information. There is a lot of marketing, branding, gimmickry and false claims. So many a times this is bordering the ridiculous. You see that they make glorifying claims, but none of them can stand the test of proper scrutiny. So the internet is easily susceptible for either glorification or vilification. This is another problem which is fairly commonly seen, and the big problem is difficulty to verify authenticity. Many people make claims, but how do you verify? So like I was telling, in the UK you would have seen people have acronyms. After F you see ABCDE and many Fs and ABCDEs. So essentially you don't know what is their credentialing. So I've seen MCH degrees being offered by some shady universities where they practically have no training, but they just get a diploma. So this is a real problem, and this is what is confusing. So like I said, you can go to those credentialing websites where you can look up that particular doctor. Now, the red flags which you have to be aware about. Now, any person who's claiming to be the first person to use an implant or a first person in this country to do a particular technique, please be careful with them. Generally, if I can talk of orthopedics, in the last 20 years there has been, when we see a real game changer kind of surgeries, there have been just 3 or 4. Rest of it are just modifications, and all these claims of first to do this is pure marketing. Even more worrisome is the speed claims. So if somebody is a speed demon, essentially he is being reckless, not conscientious when they are doing the procedure. And I've looked at ads where a surgeon was claiming to do a knee replacement in 20 minutes. Now I would avoid him like a plague, or the modern fad is COVID. So I would not get operated by any surgeon who claims to do a procedure in 20 minutes for a knee replacement. Now, there's a lot of claims of international publications and presentations, but there's no citations or there's no explanation. When you look at their profile, they claim that, but you will not see their citations. Now, there's a newer problem which has come up. Some newspapers, even some very reputable newspapers, give ratings, and many of them are actually solicited. So, there is a cash transaction involved. They generally don't have much of meaning to it. It's just financial incentives. Now, this is another reality. The internet-based rating websites, even in India, it's caught up big time. In the West, we have Vitals and Health Grades websites which rank the doctors. Now, do I personally like it? I don't, but that's a reality of modern medicine, like reality of any other profession. But what I want to strongly advocate is look at the mean and ignore the extreme good or bad reviews. So, in statistics, there's this beautiful bell curve. So, we call as two standard deviations which we define normalcy. So, when we mean, what we mean by two standard deviations is the extreme left is a negative thing or extreme right being positive, they're exceptions. So, please ignore them and look at what is a mean. So, the mean experience generally gives a cumulative idea of how good or bad the surgeon is vis-a-vis this extremes of responses. And the problem with rating surgeons or doctors is it's an emotive response to a complex human interaction. Surgery is one of the most complicated ways in which one human being can interact with another human being, and there's a lot of emotive undercurrents involved. So, using them to give a singular rating, unfortunately, is being very simplistic and naive. And it's beyond individual control. As a surgeon, I have no control of how a rating is being given. Now, both of these are something which I've picked out of the internet. Both of them are real. Now, on the left, you can see that I've taken out the surgeon's name, obviously. So, I have heard about the surgeon. He's an extremely conscientious surgeon. He's a good human being, which what I have heard. But this is a review of a complication which that surgeon has had. And you can see that the patient leaving the review has written him as an evil-minded animal. So, he refers to his father saying that what a son you've produced. He's feeding on children's blood, and refers to the doctor's kids as saying your father is feeding you by troubling other kids. So, this is an extremely emotive response. Now, making your judgments based on such decisions are generally not going to be helpful. And I'll give you the corollary response. So, here is an orthopedic surgeon. He practices in Bangalore. I know him. So, again, he's a good surgeon, by the way, but you can see that he's the best surgeon you can meet, God incarnate, magic in the hand. So, all of these things, he, essentially glorifying the surgeon, either vilifying or glorifying, is not going to be productive. So, there is a patient charter which I want to share with you guys. Please remember, when you go to a surgeon, you're not there to show off what you've read on the internet. This is something which is extremely annoying, because even if I'm the dumbest surgeon in the world, I'm much smarter than an average patient or even a well-read, Google-read patient. The reason being, it takes a lot of experience, reading, nuanced approach to become a surgeon. Now, there's a fine line between assessing competence and projection of mistrust. So, what I mean by this is, many times patients want to really know that if my surgeon is competent in delivering the care. But many times they are projecting their own mistrust, they have their own biases, they're projecting it onto the doctor, and they sit in the room not listening, but only trying to kind of have an argument. So, when you go as a patient, please have a broad mind, only look at what is in your care, and is the doctor talking in terms of what is important for the patient. Now, again, like I said, this multiple opinion syndromes, and the other important thing what's happening is they go to a surgeon A, they hide a detail, they go to surgeon B, they hide another detail. So the surgeon is not there looking at what is important for him, but he or she is there to look at what is important for the patient. So hiding details generally are counterproductive. There is sufficient data to say that people who seek out a lot of opinion, their complications are slightly higher than patients who do their research but trust their surgeon and get the surgery done. So please remember one thing, most people choose to become surgeons out of passion. So yes, we make some money, but it is, my primary motive is not to earn money. So there are much simpler ways to earn money than spend 35 years of my life getting to what I wanted. So that's the story of most surgeons. So they're there to be able to feel good about themselves, about their skills, and not just to make money. This is something which is absolutely annoying, the secret recordings. Please ask your surgeon saying that, again, this I picked up from Ken. Krakow always used to say that he always gave cassette recordings. So this was in 2012 when I was with him. So all the patients, he made duplicate copies of cassettes, one cassette to the patient and one he kept for his own documentation. And he always used to say, you can play it to your friends and family. So please don't have secret recordings. If you want to record it, please tell the surgeon. They're more than happy to let you do the audio recording. And absolutely refrain from having video recordings, because most doctors are uncomfortable to having their patient interactions to be recorded, and I think it's unethical. Now again and again I keep stressing this, financial expenditure has absolutely no relation to clinical outcome. So just because you spent a ton of money doesn't mean that you've guaranteed outcomes. By spending a lot of money, you're hopeful of getting a better care. So how do you find the hidden gems? So many a times you might not get the right surgeon. Ask the anesthesia consultant, not just in the hospital where you go, but you can ask around anesthetists. Many anesthetists are more than happy because hardly patients speak to them. So when you ask an anesthetist much before the surgery, who's a good surgeon, who's the best surgeon for this particular procedure, they'll be able to make some research and they'll be able to get back to you. So if you want a best unbiased opinion in a city or a town, you have to talk to the final year resident. So the final year surgical resident generally has reached a point in his or her life where they know about all the surgeons in town and they'll be able to get unbiased opinions to you. Now, any large hospital, there are a lot of these scrub nurses. You can talk to the scrub nurse, and all of these research can be done gently. None of this is illegal. You can talk to people and talk to a scrub nurse in a large hospital and find out who's a good surgeon in that particular hospital. So scrub nurses are some of the best judges of surgeons, not just of their skills, but of their attitudes and temperaments. So when you ask them, they'll be able to give an unbiased opinion who's a good surgeon in that particular institution. Except niche procedures, say something like a knee replacement or cardiac valve replacements. Many routine procedures, when you look at trust hospitals, so trust hospitals have large volume and surgeons working there will have a lot more experience. So trust hospitals generally have very competent surgeons in routine surgical care. Now, like I said, empathy and all of these are extremely important, but when we look at certain problems, something like a patient needs a liver transplant or a pancreatic transplant, I will get it done by a surgeon who has got the worst personality but who's got great skills, because those are surgeries where in the entire country you might have 5 to 10 of them who do that extremely well, and in those kind of surgeries, please ignore their personality. Generally, to reach to the point where they have reached, they would have made huge sacrifices, and you might not have the most pleasant personalities left in them to reach where they are. So in extremely complex procedure, it's not the personality, it's just the skill and the dexterity which makes the difference. So hopefully guys, this small talk would have helped you to make the decisions about picking the right surgeons. So happy hunting, finding a surgeon when you need them. Thank you guys.